Okay, so now we're going to talk about effects of the neoplasm. There are both neoplastic effects, meaning the effects of the actual tumor on the actual tissue around it. There's also paraneoplastic effects, meaning effects distant from the neoplasm. So for neoplastic effects, we're talking primarily about the local environment. We're talking about effacement of normal tissue. So is it invading? Is it destroying? Are we losing function of whatever that tissue is? If it's a benign lesion or if it's getting pretty large, you can cause pressure atrophy on surrounding tissues. If it's rapid, it's going to be pressure necrosis rather than pressure atrophy, right? Because atrophy takes time to adapt to. If you're in a lumen, it can grow into a lumen, so that pheochromocytoma growing into this lumen of the vena cava, that can become obstructive. Here we have a large tumor growing into the third ventricle or the lateral ventricle of the brain that's causing pressure atrophy. It's causing obstruction of CSF outflow, and you're getting a little bit of hydrocephalus. And then it can act distantly. So if we're seeding the bloodstream, you can get emboli. These can cause infarcts where they land in tissue. You could get hemorrhage associated with those infarcts. Tumors can also be painful depending where they are, what they're involving. Are you involving somewhere that's highly innervated, a lot of nerve tissue? They also can be associated with significant inflammation, especially certain types of tumor, especially tumors with a lot of necrosis. Remember, because necrosis is pro-inflammatory. So you're releasing all those things like ATP and inside cell parts that are on the outside, and that generates a lot of inflammation. And then I've said this before, but remember that you can have a histologically benign tumor still have malignant effects and life-threatening effects if it's in the wrong place and causes the wrong thing to the wrong thing. So some of you guys. It was so
We feel
I know. You know what I'm saying. It's up there. That's why I wrote it down. Okay. Paraneoplastic effects. So these are a little bit less obvious and more interesting. I think this could be the whole PhD topic for somebody, different paraneoplastic effects. Para means around. So these are syndromes that occur around the neoplasm. They are secondary to the neoplasm, so they're caused by the neoplasm, but they're at distant sites. So these are things that are going to enter the bloodstream and act usually systemically or somewhere distantly. In humans, about 10 to 15 of cancer patients will have some kind of paraneoplastic effect from their tumor. Some of these are kind of general to any chronic tumor. Others of these are more specific to a specific tumor type. So with many different kinds of tumors, especially malignant tumors, you'll see cachexia. And this is that whole body wasting. It's loss of fat and muscle. And it's due to chronic cytokine upregulation, specifically IL-6 and more so TNF-alpha. TNF-alpha is actually called cachexin. So this is the primary mediator of cancer cachexia, but also the cachexia of chronic inflammation, right? Some specific tumors can actually produce and release biologically active substances. So for example, an endocrine tumor, if it's well differentiated, if it's acting like the cell type of origin, that function is to produce hormones, right? So there are endocrine tumors that can be functional and producing hormones ectopically and autonomously, meaning the body has not signaled them to produce hormones. In fact, the body may be signaling them, hey, I've got enough hormones. Can you knock it the F off, please? And the tumor's like, no, do my job. So you can get hormone secretion in the face of negative feedback. You can also get ectopic hormone produced by tumors that do not normally produce hormones, meaning the cell type of origin is not an endocrine cell. This is, it's called PTHrp or parathyroid hormone related protein. It's basically a mimic of parathyroid hormone, and it causes the effects of parathyroid hormone excess in the body, which we'll talk about in a second. Vasoactive amines, so especially histamine produced by mast cell tumors. A lot of anti-GI ulcer or GI protectants are antihistamines. So increasing histamine can increase the amount of acid in the stomach and lead to GI ulceration. So that'd be a paraneoplastic effect of a mast cell. And then there's some weird ones, others are pretty rare, and they're associated with specific tumors or types of tumors. So if you see them, if you see this effect, you're like, oh, I should go looking for this tumor. These are clinically important because occasionally you'll see the paraneoplastic thing before you see the tumor. And that will be your indicator to go looking for something, right? So you'll have a cryptorchid animal with a testicular tumor. Won't know, you might not know about the cryptorchid testicle, you definitely won't know about the tumor, but this animal might present the signs of hyperestrogenism. You'd be like, that's weird, why is this animal producing too much estrogen? Have I given it something to make estrogen? No. Is there a tumor somewhere making estrogen? It's gonna be my second guess, right? So these are clinically important. Cachexia, again, this is whole body wasting. It's two components. You're losing fat, but you're also losing muscle. So when an animal is in negative energy balance, you will preferentially lose fat first, then muscle. With cachexia, you're losing both, so you're down to nothing. You're literally skin and bones, right? It's a full syndrome, so it also goes with all these other clinical signs. Animals can be anemic, they're anorexic because these cytokines, TNF and IL-6 and IL-1 make you feel like crap. They make you nauseous, they make you not want to eat. And at the same time, they're increasing your own like auto digestion of your body, right? You need to mobilize fats and proteins so you start digesting them yourself. There is no treatment for this except to get rid of the thing that's causing it. So get rid of the chronic inflammation, find the tumor, take it out. All day long, have good luck. No. Don't memorize this, please, unless you want to become a pathologist, which do want to become a pathologist. But this is complicated stuff, y'all. It's like the microenvironment. There is a lot going on between the tumor and the entire body in cancer cachexia. So lots of effects distant from the tumor, some of them yet to be worked out, right? We know the tumor has an effect on the pancreas, on the GI tract, but we're not really sure yet how that works. So this is still an open question. Hormone production. So tumors of endocrine origin, either benign or malignant, can produce hormones, as well as some non-endocrine tumors. So some of the more common examples in animals, a thyroid adenoma, is that benign or malignant? Benign, thank you. What species usually gets thyroid adenomas? So overproduction of T3 and T4 by the neoplasm leads to clinical signs of hyperthyroidism. Insulinoma, benign or malignant? What's the cell type of origin?
Beta cells.
Can't fool you guys. Why isn't it a beta noma? Because that sounds dumb. No one would pay me if I said words like beta noma. So an insulinoma is a histologically benign but potentially clinically malignant tumor of beta cells of pancreas, overproduction of insulin, hypoglycemia, seizure activity. So these are often teeny tiny. They can be really hard to find, but they can be functional. So you will have a huge paraneoplastic effect and difficulty finding this tumor in most cases, unless it's a ferret. And then if it presents with these signs, you can just assume it has an insulinoma. Renal carcinoma, benign or malignant? Malignant carcinoma produces erythropoietin. What does that do for us? Makes the blood go. So if we are producing too much erythropoietin, what does this mean? Too many red blood cells, not necessarily immature. So what's gonna be the next error? How is this animal gonna present polycythemia? What's gonna happen if you have too many red blood cells in your blood? Your liver damage, like your hyperemia?
Heart problems?
Heart problems? What kind of heart problems? This dog comes to you in a clinic. It has renal carcinoma and polycythemia. What are you gonna see?
Hypertrophy?
Hypertrophy, if it's been going along on a long time, cardiac hypertrophy,
Heart failure?
heart failure. What else? Go back through all the weeks of this class, all the possible ways that a thing can go wrong. What is this animal? What is the consistency of this animal's blood? Like molasses. What's gonna happen to your organs and the rest of your body if you have molasses blood and not blood?
Hypoxia.
Lots of hypoxia. What else? Ischemia. Why is ischemia?
Not getting it off.
Give me a T word. Thrombosis. Do you think if you have too many red cells, you might be hypercoagulable? I think you are for sure. So this animal is at risk of thrombosis.
Why do you get?
Because the blood must flow like the spice.
Not a hearing thing, it's explode.
Most of your capillary beds are the size of one red cell, so they have to go through their single file. That's not gonna work if they're overpopulated by a lot. What's the treatment for this? Bloodletting! You remember? Sertoli cell tumor in males. Where is this? Where are Sertoli cells? In the testicles. So Sertoli cell tumor in male, especially a cryptorchid male, these can produce estrogen, leading to signs of feminization and hyperestrogenism. Estrogen is also a bone marrow suppressant, so they can get signs of bone marrow suppression. Multiple cytopenias. Adrenal or pituitary neoplasm, these can produce just read it. I give up. Cushing's happens. Any questions about hormones? I almost stuck this in my mouth, you guys.
All.
Oh. The last two usually benign, the cervical and the adrenal.
There are benign and malignant versions of this. Most of the time they're benign. I don't think I've ever heard of one metastasizing, but it could probably theoretically happen. This can be either or. They can be benign or malignant and functional. Same with this. Thyroid carcinomas can be productive. It's much more common to have thyroid adenomas that are productive because thyroid adenomas are a cat thing and thyroid carcinomas are a dog thing. Dogs are more likely to be hypothyroid. Thank you for coming to my endocrine TED Talk. PTHrp, so parathyroid hormone related protein and hypercalcemia of malignancy, also called HHM, humoral meaning of the blood, moral hypercalcemia of malignancy. So this is produced by a handful of different tumors in animals. These are the most two common suspects. These are usually produced by non-endocrine tumors, PTHrp. It is essentially the same as PTH, so it has similar functions. It is responsible for calcium homeostasis, except since it's being produced by a tumor and not a parathyroid, it's putting you out of calcium homeostasis instead of into it, right? So production of this by the tumor, this goes into the bloodstream, it stimulates the same things that PTH would stimulate, and you end up with hypercalcemia. So hypercalcemia of malignancy. Very common in lymphoma, extremely common in Agasaka, anal sac adenocarcinoma. Since these are highly malignant and met early, if you see a dog with hypercalcemia and no other signs, go stick a finger up the butt right now. Look for one of these guys. I ain't playing, y'all. If it's a lymphoma in a dog, you're probably going to know about it because it's going to have lumpy lymph nodes. Lymphy lymph nodes, bulby nodes. If you don't feel big nodes and you have hypercalcemia and you've gone through the list and there's nothing else, go looking up the pooper. All right, some other neoplastic syndromes. I think I had a case of this in lab. Beginning, there were really big, thick pig legs. So hypertrophic osteopathy is a condition where you get formation of new bone along the periosteum of long bones. It's often in the distal long bone, so kind of distal radius, digits. Here's a paw or a hand, basically, and all this white new bone is periosteal proliferation of new bone. Pathogenesis of this, no clue. do a PhD on this topic. I would love to know what causes this. It is associated with disease in the chest, malignant disease in the chest, or severe granulomatous inflammation in the chest, but also random things like ovarian tumors in horses and this very specific urinary bladder tumor of young dogs. So no clue what causes this, but it's pretty crazy. This is painful. This might result in clinical lameness.
For that one, as compared to osteosarcoma.
Huh?
This is more like a sheet of bone.
This is non-neoplastic bone. This is a response of the periosteum to these things.
A cancer or other things somewhere else.
Yes. Yes. So paraneoplastic responses are not neoplastic themselves. They're caused by the neoplasm, but this is not neoplastic. That makes sense? Paraneoplastic alopecia. So cats with abdominal cancers, especially pancreatic, but also hepatobiliary. These are malignancies. So we're talking about abdominal carcinomas in cats. They get weird shiny alopecia. It's super shiny and weird. If you see this in a cat, you may as well just euthanize it because the tumor has already metastasized by this time. So this is one where the paraneoplastic effect is not helpful. It might tell you what it is. Like I know where in this cat to look for disease now, right? But when I look in there, it's going to be probably too late by the time skin lesions develop. Any questions on paraneoplastic or neoplastic effects?
Paraneoplastic effects don't have to be from neoplasia, they're just side effects that look like neoplasia, or they are things that could.
Paraneoplastic effects occur secondary to neoplasia. This one also occurs secondary to granulomatous thoracic disease.
Oh, so this one is kind of an exception.
It's not though, it is a paraneoplastic syndrome for the most part. But we don't know the pathogenesis, so whatever is mediating that in these is also mediating it in some inflammatory disease, but it's specifically granulomatous and in the chest. If you asked me to guess, I would assume it has something to do potentially with vitamin D metabolism, and macrophages produce a vitamin D analog and have weird calcium things, but I don't know how that interacts with the rest of these.
Are these considered like pathognomonic, like if you don't see it, you can't rule it out, but if you do see it?
Some of them are, some of them aren't. So is hypercalcemia pathognomonic for lymphoma or anal sac adenocarcinoma? Is it pathognomonic for neoplasia? You haven't heard hard ions yet? Hard ions G? It's all the causes of hypercalcemia, HARD-IONS-G. So no, not just tumor. What about this one? Is this pathognomonic for abdominal carcinoma? Yeah, pretty much. Alopecia, no. Weird shiny alopecia on the ventral abdomen that's progressive and non-pruritic. Pretty much.
Is that because it's metastasized skin? Right, nerval.
No, I don't know why this is. Yeah. So in general, paraneoplastic effects are not related with direct effects of the tumor. So they're not because of like metastasis or like local involvement. I would consider those as neoplastic effects, not paraneoplastic.
Is it usually from some kind of thing they secrete?
I think often the ones that we know about. There's a lot that we don't know how they work.